Welcome to Grand Rounds. It's my pleasure. I'm Dave Notrika. I'm the program director for the Pediatric Surgery Fellowship, and it is my pleasure to introduce our speaker today. Dr. James Prieto is our second-year fellow. So James grew up in New York. He matriculated and graduated from the United States Naval Academy, where he excelled. After finishing at the Naval Academy, he went to the Uniformed Services of the Health Sciences in Bethesda, Maryland, where he excelled again, and then matched into a general surgery training program back in San Diego with the United States Naval Academy, with the United States Navy. He went through his general surgery training and excelled, and we matched him as our top choice for a pediatric surgery fellowship, and he has met every one of our expectations as a fellow. When he finishes, he will be going back to Virginia, where he will serve the United States Navy at Portsmouth in Virginia. It's my pleasure to introduce him. He'll be talking today about contemporary management of spontaneous pneumothorax in the pediatric population. James, thank you.
Thanks, Dr. Notrika, for that really nice introduction. I appreciate it. And thank you to Phoenix Children's for allowing me and giving me the opportunity to present here at Grand Rounds today. I have no disclosures. And so, I chose spontaneous pneumothorax as a topic to talk about for Grand Rounds. And by no means is it the most interesting thing that we deal with as pediatric surgeons, and it's certainly not the reason that many of us chose to pursue pediatric surgery. But the reason I chose it is because it's a common diagnosis with a lot of different diagnostic and management strategies. And these management strategies can vary from institution to institution, and even from surgeon to surgeon or ER doctor to ER doctor within the same hospital. And so it's an area that seems ripe for development of a protocol. And as we know in medicine, any protocolized approach to certain diagnoses can promote consistency, increase patient satisfaction, and limit medical errors, and decrease cost for both the patient and the hospital. So my objective in preparing for this talk was to do a comprehensive review of all the available literature and present the most recent data on management strategies and recurrence rates that exist. And the caveat to this, or the disclosure that I have for this, that spontaneous pneumothorax tends to occur in not only adolescent males, but young adults as well. And so some of the literature and some of the evidence that I'm going to present here does apply to the adults or the population of patients who are in their 20s and 30s. And then the second reason that I chose this was that I have some personal experience with it. As a third-year medical student 12 years ago, I walked around for a week with pleuritic chest pain, and it took me, I diagnosed myself with costochondritis and pulled muscle, and then finally 5 days later ended up in the emergency room with a spontaneous pneumothorax. And to make a long story short, it actually had a profound impact on me, and is one of the major reasons that I ended up going into general surgery. And so as I end the 9 years of training here in the next 2 months, I thought sort of what more of a fitting topic to talk about than one that led me to my interest in general surgery in the first place. So just to get some definitions out of the way, a primary spontaneous pneumothorax is defined as a pneumothorax in someone without any underlying lung disease or injury. And as I mentioned before, there's significant variation in practice patterns, and some literature has even demonstrated that a patient's socioeconomic status can affect their ultimate management strategy. And so therefore, a more protocolized approach would be beneficial from both an institutional and a patient perspective. So once again, patients with a primary spontaneous pneumothorax, they don't have any sort of underlying disease in the lung itself, but they often can have disorders that predispose them to developing pneumothorax. For example, patients with Marfan syndrome, Ehlers-Danlos, or Loeys-Dietz may have connective tissue defects that leave them vulnerable to the development of lung blebs, which can then rupture and then cause the pneumothorax. Examples of a secondary pneumothorax would be someone with underlying asthma or cystic fibrosis or malignancy, anything that predisposes them to developing an air leak And then I also included traumatic pneumothorax as a separate category here. And this categorization is important because although they may have very similar looking chest x-rays, they all have air outside of the pleural, outside of the lung in the pleural space that needs to be evacuated. Their management patterns are very different. And so classifying what type of pneumothorax a patient has when they present is an important first step. This is predominantly a disease of young adolescents and more common in males. Patients, for whatever reason, are commonly tall and thin in nature. And there have been a lot of attempted explanations for why tall, thin males tend to develop blebs in the apices of their lungs. But to the best of my knowledge, nobody has really been ever to establish a scientific explanation for why that happens. There are theories as to rapid growth craniocaudally and pressure differentials at the apex of the lung relative to the hilum, but nobody's ever really been able to prove why this occurs. And then there is a known association with smoking and vaping. And as I mentioned, patients with connective tissue disorders. For example, patients with Marfan syndrome have a reported incidence of about 10% in their lifetime of developing spontaneous pneumothorax, which is far greater than the general population. So what are these blebs? This is the mechanism by which a spontaneous pneumo is thought to occur. Blebs are blister-like air pockets that tend to form at the apices of the lung. They're almost always found at the apex. And again, there's a lot of bleb theories out there, but none worth presenting as a definitive mechanism for why these form. Essentially, what happens is the blebs rupture and cause leakage of air into the pleural space, and then the patient develops the spontaneous pneumo. Blebs can sometimes, but not always, be seen on chest x-ray. This is sort of a dramatic example of a large apical bleb with a pneumothorax just above it. And then this is what they would look like intraoperatively. Obviously, the patient there on your left probably is a smoker, but more commonly what we've seen is this picture on the right with these simple appearing air pockets at the apex of the lung that have ruptured and then leaked air into the pleural space. When we don't find the blebs at the apex, as we're expecting, then typically the next most common location is to look at the apices of the other lobes of the lung. Patients typically present with chest pain. It's specifically pleuritic in nature, and they may be short of breath. They might be tachypnic, they might be tachycardic, and chest x-ray is sufficient for diagnosis. And I'll definitely talk about this more, but you don't need to obtain a CT scan in patients with a primary spontaneous pneumothorax. The most feared complication of any pneumothorax, and one that we're always taught about from medical school on, is tension physiology, where the pressure from air in the pleural cavity becomes so great that the mediastinum begins to shift, the superior vena cava is compressed, and then venous return to the heart is impaired. Patients can rapidly decline with hypotension, tachycardia, and even cardiac arrest. But the point I want to emphasize is this is exceedingly rare in patients with a spontaneous pneumothorax. While they'll often present with very dramatic and large pneumothoraces with a tiny little nubbin of a lung in the hilum, many of them are simply symptomatic, but don't have any physiology that suggests tension. For whatever reason, I can't explain, and I wish I could say that it never happens, but there are a few case reports in the literature of tension physiology developing through a patient with a presumed primary spontaneous pneumothorax, but it's typically not a primary concern. So the treatment goals, just to establish what we're trying to do here, is to evacuate the air from the pleural space in order to expand the lung and obtain good apposition of the visceral and the parietal pleura. And in addition, we want to do this in a way that minimizes morbidity and prevents recurrence. So now that we've discussed the basics, what are our options when a patient presents with spontaneous pneumothorax? I've broken it down into 4 major categories, and I'll talk about each one and their advantages and their disadvantages. The first option is to do nothing, or nothing invasive at least. We observe the patients, we confirm that they're stable, both physiologically with vital signs and monitors, and then radiologically with a repeat chest x-ray to confirm that the pneumothorax isn't enlarging or maybe even is improving. This might involve observing the patient in the hospital overnight, especially if their social situation makes follow-up more difficult. In order to qualify for this treatment strategy, patients have to have reassuring vital signs on presentation and minimal symptoms that don't require excessive pain control. The theory behind this approach is that oftentimes a small air leak from a ruptured bleb has healed itself, maybe even by the time the patient is presented to the hospital. And all you need to do is wait for the air to reabsorb in order for the lung to re-expand. One of the questions that comes up when deciding whether or not a patient is appropriate for observation is how large is the pneumothorax? Do the radiologists call it small, moderate, large? Oftentimes it's simply a gestalt. The surgeon or the emergency room physician looks at the chest x-ray and decides whether or not the pneumothorax looks small enough to observe. But for reference, there are a number of ways, standardized ways of quantifying just how large a pneumothorax is. And I don't think the radiologists are just making up small, moderate, or large. For example, the American College of Chest Physicians classifies pneumothorax size based on the distance from the apex of the lung to the apex of the chest cavity. And anything greater than 3 centimeters, they would consider a large pneumothorax.
If you're using the mouse, you want to move it over to the other side.
Oh, yeah.
There you go, right there. Okay.
And then the British Thoracic Society measures the distance between the hilum and the chest wall, and then the difference here between the pleura and the chest wall. And then there are a number of other complicated formulas that involves these A, B's, and C's that I put up here that then come up with a percentage size of the pneumothorax. But the point of this is, while it's helpful to have sort of a reference, sorry, I'm just trying to get my mouse back. There we go. It may be helpful to have a reference and a standardized way of discussing pneumothoraces with each other. It's probably more important what the patient's symptoms and vital signs are rather than what the chest x-ray looks like. And I think this paper sort of encapsulates that idea nicely. This in the Journal of Medicine 5 years ago. The authors randomized patients with pneumothorax into what they called conservative or interventional groups. And the conservative group essentially was an observation, and the interventional group received a chest tube. The important thing to notice here is that they only included patients with a large pneumothorax, so something that was greater than 32%. So these are patients that by most standards would not typically meet criteria for non-operative management. Typically, when patients present with a large pneumothorax, especially when they present not to a children's hospital, would receive a chest tube almost immediately. And for reference, if you're saying like how big is 32%, it's about 4 rib spaces, so a fairly sizable pneumothorax. So patients who underwent observation were observed in the ED for 4 hours, and then they had a repeat chest x-ray. If they were clinically stable and the chest x-ray was stable, then they were discharged home. And then the primary outcome was resolution of the pneumothorax by 8 weeks. The important thing to take away from the chart here is that obviously the patients who underwent this observational management had a shorter length of stay, but then even more importantly, only 15% of them progressed to needing some type of intervention during the study period. And so 85% of patients in the observation group with a large pneumothorax avoided any kind of intervention. And so they concluded that observation is a safe strategy even for patients with a larger pneumothorax. Oftentimes, when we go down to the emergency room to see somebody with a spontaneous pneumo, they're on a non-rebreather. And that's not because they're hypoxic on presentation, but more so because there's this theory that if you place a patient on 100% oxygen with a pneumothorax, that perhaps the pneumo will be reabsorbed quicker. And the rationale is that you're reducing the partial pressure of nitrogen in the inspired gas, and then the rate of nitrogen absorption from the pneumothorax should increase, which would make the air dissipate faster. From what I can tell, most of this is based on some studies from the 1970s that demonstrated faster resolution of pneumothoraces by placing a patient on 100% oxygen. But really, the data doesn't support that this has any clinical utility. And if there is a benefit, it's hard to detect clinically. And also anecdotally, when you put a kid on a non-rebreather in the ER, it sort of escalates the severity of the situation and may sort of overblow how severe it is and sort of defeat the purpose of what you're trying to do by just observing them and potentially discharging them that same day. So the next option available is chest tube placement. A tube is placed in either the ER or the operating room with some type of sedation. A chest tube can rapidly evacuate the pneumothorax and achieve immediate lung expansion. And then once the chest tube is placed, there are numerous protocols that can be used with respect to how it's managed and when it's removed. These are some diagrams that depict what would be considered surgical chest tube placement, but the truth is that most of these tubes that are placed nowadays are done with the Sullinger technique and are much smaller caliber, which brings me to the next point, and that is what size tube should you use if you're going to place a chest tube. There are a lot of studies that address the proper size chest tube for spontaneous pneumothorax, and a number of retrospective studies and meta-analyses have evaluated smaller bore tubes, which would be considered 8 to 12 French versus a 14 French or greater, and there's no difference in efficacy between the tube sizes. And the tubes shown here on your left would be a larger surgically placed chest tube, and the one on the right is a smaller bore tube that's typically placed with a needle, wire, and a dilator. And from personal experience, I can tell you that a 32 French chest tube is much more painful than a smaller bore chest tube. So once the tube is in, it's typically placed to suction in order to evacuate the pneumothorax. And within varying periods of time, it's transitioned off of suction to a water seal setting and then eventually removed if there's no air leak. And the patient's management is typically dictated on whether or not an air leak is present. If we do note an air leak, which is depicted here in this video with bubbling from a pleurovac, then that suggests that the ruptured blood hasn't healed. There's still air leaking from the lung, and we have to proceed to more definitive surgical management, which I'll get to in a moment. And we try to make this decision within 48 hours. I'll present some evidence that shows why we sort of choose that cutoff time or why that cutoff time is typically cited in the literature. The third option is what is referred to as aspiration. This is slightly different from chest tube placement, where a small pigtail tube or a small bore catheter is placed in the chest and the air is evacuated. It's quickly removed if there's no air leak, and the patient is oftentimes discharged the same day. The advantage of this approach is that it allows for same-day discharge, and it's less invasive than more formal surgery. The disadvantages are that, one, there's an inherent risk to any procedure that we do, so comparing this to observation. And then two, this is a pretty big burden for the emergency department. It involves the use of sedation, increased time in the emergency room, and increased bed usage, and potentially even the ER physician performing the aspiration procedure. And lastly, which we'll talk about in a bit, there's going to be increased rate of recurrence when you compare it with our more definitive surgical management. This is a great example of an aspiration protocol, and you may notice some familiar names on this paper, which features Dr. Osley and Dr. Frazier. And I put aspiration in quotes only because when I think of aspiration, I think of like placing a needle into a space, drawing back on a syringe, and then being done with it. And while this is different than a chest tube placement, it still does involve the placement of a pigtail catheter, which some people would refer to as a chest tube. So in this pilot study, patients with moderate to large pneumothoraces or greater than 2 centimeters were treated with a simple aspiration protocol. They placed a small bore catheter into the chest, placed it to suction, and then obtained a chest x-ray just to make sure that the lung had re-expanded. Then they capped the catheter for 6 hours and repeated a chest x-ray. If the lung was still adequately re-expanded, then the tube was removed and the patient could be discharged home the same day within 6 hours. If the lung dropped further, then the patient proceeded on to either chest tube management or immediate surgery. And I think that decision was based on sort of surgeon preference and discussion with the patient. There was about a 50% initial success rate for patients that underwent aspiration. So you can see here they had 33 patients total and 16 of them were successful. Another 12 patients then proceeded to chest tube management, which would essentially just mean putting this back to suction and then waiting for the air leak to resolve and eventually moving the chest tube. But over 50% of them were able to be discharged. And they followed these patients for at least a year. And you may look at the aspiration protocol and say, how is that really that much different from a chest tube management protocol, and why does it really matter? And the answer is that it has the potential to significantly shorten a patient's length of stay and a hospital's use of resources. This graph is from a paper that was done in a retrospective study out of Lurie Children's in Chicago, which looked at the timing of surgical management in patients who were undergoing chest tube management for spontaneous pneumothorax. There were a number of significant findings in the paper, but what's most striking is that the longer time a patient has a chest tube in, the more likely they are to proceed to surgery. So, and even if they have a chest tube for longer than 48 hours, it's almost 100% likely that they're going to proceed on to surgical management. So the point of this, the reason I bring this up is that because if you think back to the aspiration protocol, they were able to answer this question in 6 hours rather than 48 hours for a large number of patients about whether or not they were going to be effectively managed by a chest tube. And so that's a fair number of patients that you're able to potentially discharge the same day, as opposed to admitting with a chest tube and waiting for 24 or 48 hours before they're able to have the chest tube removed and go home versus proceed directly on to surgery. And going back to this aspiration paper, after looking at this, you might say, why would anybody want surgery? But the answer is the recurrence rate. If you look here, there's half of these patients that were aspirated successfully, or more than half, ended up ultimately recurring on the same side. And then more than half of these patients that were managed with a chest tube after failing initial aspiration recurred as well. So that's where the argument for surgical treatment comes in. And that's not to disparage aspiration, but it would certainly be like one of the counterpoints to it. So what is surgical treatment for primary spontaneous pneumothorax? It's done thoracoscopically, meaning we use small incisions in the camera, and then typically involves at the very least a stapled resection of the apex of the lung, the portion of the lung that contains the plebs. Even if we don't see gross pleb disease on initial exam, a wedge resection is typically done under the assumption that there are small plebs within the apex that have caused the pneumothorax to begin with. The postoperative pathology often supports this as well, with the pathologist demonstrating that there were plebs there, even if you didn't see them intraoperatively. In addition to blebectomy, a pleural procedure is often performed, where the goal is to incite inflammation that allows the lung to stick up to the chest wall and potentially decrease the risk of recurrence. The patient receives a chest tube in the OR, which is typically left in for at least 2 to 3 days after surgery. The options for that pleural procedure that I put in quotes are here. We can perform a mechanical pleurodesis, which is essentially where we use sterile sandpaper to scrub the side of the chest wall and incite inflammation and minor bleeding. An apical pleurectomy is where we physically strip the pleura from the inside of the chest wall. And again, it's a sort of a similar concept to what the mechanical pleurodesis is. And then lastly, we can instill medication into the chest cavity to cause additional inflammation. And some examples of this are doxycycline, minocycline, betadine, and talc. So what's the best option? There's a lot of different combinations that you can use. Pictured here on this slide is a pleurectomy being performed. This chart is from a study that was done in Rush Medical Center. They used a database to retrospectively look at patients who had undergone a blebectomy with either a pleurectomy or a mechanical pleurodesis. And because of the database characteristics, they were able to follow the patients for 5 years out from their initial operation. Not surprisingly, these are two very similar techniques in terms of what the concept is behind them. They found there was no difference in recurrence rate and no difference in pain or opioid use between the two groups. So now that we know that pleurectomy and mechanical pleurodesis are similar, should we be adding a chemical pleurodesis? What's the role, I guess? So there's some literature suggests that the addition of one of these agents may further reduce the recurrence risk when combined with blebectomy and mechanical pleurodesis. But the data is mixed. It's really difficult to interpret because there are so many different chemical agents available. And in addition, chemical pleurodesis is notorious for being extremely painful and requires increased postoperative opioid use. As an example, I'll bring up this paper which compares the addition of either minocycline or an iodine solution to blebectomy, and they found no difference in recurrence rates, but a longer length of stay in patients who receive the iodine. The literature is full of papers with sort of similar comparisons, and it's quite honestly very difficult to make heads or tails of it. But ultimately, what ends up coming up as a sort of a universal objection to the use of chemical pleurodesis is the potential for negative effects. Patients almost unequivocally have worse postoperative pain. There is some association with chronic pain, And there's also a concern, although I don't know if it's really validated, about whether or not they could potentially have impaired lung function as a result of some of these chemicals that are instilled. And so what we find most frequently is that chemical pleurodesis is used in patients who recur after surgical treatment of spontaneous pneumothorax. And that's beyond the scope of this talk, but the bottom line is that it's very infrequently used in pediatric surgery. So another question is pleurodesis even necessary? This is a popular subject of debate, whether or not you have to do a pleurodesis in addition to the blebectomy. If you remove the source of the problem by performing a wedge resection and removing the blebs, then is there really anything left to do? The thought behind doing a pleurodesis is that oftentimes when we have to reoperate for a patient with recurrent pneumothorax after a VATS blebectomy, there are new blebs that have formed. And so if you incite inflammation along the chest wall and cause lung adhesions to form and cause the lung to stick up to the chest wall, then perhaps if and when a patient develops recurrent blebs and they rupture, the lung is less likely to fall away from the chest wall and they're less likely to develop a pneumothorax again. There's a lot of evidence on both sides. You could sort of probably pick your favorite paper and support your argument about whether or not you should be doing mechanical pleurodesis. But this is a randomized controlled trial from China where patients who were undergoing a VATS wedge resection for spontaneous pneumothorax and bleb disease were randomized to either receiving a mechanical pleurodesis or not. The authors found no difference in recurrence rates between the two groups, and they also found that those who had undergone a mechanical pleurodesis had increased chest tube drainage, increased intraoperative bleeding, and increased time with the chest tube postoperatively. Luckily, 2 years ago, the American Pediatric Surgical Association did sort of a comprehensive review on most of the available literature on this subject in children. And they did a pooled analysis of recurrence rates. So this is not the greatest data, but this is what they came up with in terms of overall recurrence rates for these different surgical techniques based on the studies that they included within this sort of meta-analysis that they did. They found that blebectomy alone, or wedge resection alone, had a recurrence rate of about 15%. Blebectomy plus mechanical pleurodesis was 9%. Chemical pleurodesis, interestingly, was a little bit more effective. And then if you do a combination of all these techniques, perhaps you get a little bit of decreased recurrence as well. Based on that, they by no means recommended necessarily doing a chemical pleurodesis, but they said that blebectomy plus a pleural procedure is a recommended strategy to decrease recurrence in these patients who you're going to operate on for spontaneous pneumothorax. They are not necessarily advocating that primary surgery is the best treatment choice. But if you are in a situation where you're going to surgically manage these kids, blebectomy and a pleural procedure is their recommendation. And I think they gave this like a grade C recommendation based on that level of evidence that they had available to them. Post-operatively, patients are managed with a chest tube for at least 3 days or so. It's a very painful operation, and non-opioid adjuncts, just as in anything we do, are typically the first line pain control options. Historically, and in surgical dogma, anti-inflammatory medications were avoided in patients who underwent any sort of pleurodesis, the thought being that if inflammation is the goal in order to achieve these pleural adhesions that would then decrease recurrence in the future, then you should avoid things like ibuprofen or Toradol. And the truth is that probably is not true. There's a good amount of literature to suggest that Toradol is safe to use post-operatively and doesn't necessarily decrease a patient's risk of recurrence, and probably is much more effective in terms of decreasing opioid use and decreasing post-operative pain and patient satisfaction. So I think that that's been fairly well disproven in the literature. So after sort of seeing all this data, what are the recurrence rates and what are the numbers that we should be telling our patients when we're counseling them on the different options that they have available to them? It's, admittedly, the recurrence rates are variable. They're a bit all over the place depending on what you're reading. It depends on the length of follow-up. Some of these studies, especially in kids, have a difficult time following them into their adult years. So there's a lack of data to make decisions on. And we know from the literature that younger patients may have a higher recurrence rate. So when you're evaluating these papers that take into account more of the 20 to 40-year-old range, you have to keep in mind that a 15-year-old probably has a higher lifetime rate of recurrence than does a 25-year-old who's presenting with spontaneous pneumothorax. But overall, best we can tell, non-operative management, which I've lumped in here to the observation, aspiration, chest tube category, is somewhere in the 30 to 60% range in terms of reported recurrence rates. And bulbectomy and plus or minus pleurodesis is somewhere in the 5 to 20% range. 20 would be at the higher end of this. I think most people would say somewhere around 10 to 15. And so based on these recurrence rates, you might say, why not just do surgery first? Who wouldn't want surgery to decrease the rate of recurrence so that then this doesn't happen again? And so this is a study from Florida, which sort of advocated for that. They divided all these patients presenting with a primary spontaneous pneumothorax into non-operative and operative groups, and they found observation was a 33% recurrence rate, chest tube management 58%, and primary BATs 14%. I think although there's not in this study a difference in terms of recurrence rates based on the size of the pneumothorax, you can sort of suggest that the patients in the chest tube group are almost like self-selecting for recurrence because they're the patients that have larger pneumothoraces, are more symptomatic, and probably have an ongoing air leak when they present to the ER. So, of course, they're more likely to ultimately end up proceeding to surgery in the end. One of the things you have to take into account, though, is also cost efficiency. So this is a study that I think is like almost 20 years old now, but I think still applies, at least in concept. They looked at patients presenting to their hospital with a spontaneous pneumothorax and found a recurrence rate of about 54% for non-operative treatment. And then they compared the cost of non-operatively treating somebody with a pneumothorax versus operatively treating. Of course, surgery is more expensive because it involves OR time, a longer hospital stay, et cetera. But what they found is that in order to financially justify a surgery first approach, you'd have to have a recurrence rate of upwards of 70% in the non-operative group. And so, again, just from a cost perspective, it wouldn't be fair to say, oh, we should do primary surgery just to reduce rate of recurrence. It still is more costly based on the data that we have about recurrence rates for the non-operative management of spontaneous pneumothorax. So who should get surgery up front? Certain at-risk occupations are recommended. So pilots, scuba divers, athletes, the thought being that when there are different pressure changes that can cause the air within the thoracic cavity to expand, these people are more likely to potentially be in a life-threatening scenario where they're not able to get the help that they need. Patients in remote locations and patients who have limited access to care, which is applicable in some ways to some of the patients that we see here at PCH who come from areas where they may not have the same access as people here in the relatively close to the Phoenix Children's Hospital. And so I think I've noticed that some of that plays a role in the way that some of the attending surgeons here will counsel patients and advise them on what their options are. And then I think it's also important to note that, I mean, somebody who just wants primary surgery should be able to get it as well. If you counsel patients sort of objectively on what the recurrence rates are for these things, I think a 50% recurrence rate to one person may mean a completely different thing as compared to another. So somebody might look at that and say, you know, I'll take my 50% chance of not needing surgery in the future. Whereas others would say, absolutely not. Do I ever want to deal with this again? And I want to decrease the risk that, you know, that I have a recurrence. But I think it's important to remember that, you know, as surgeons, when we see these kids and their families who are obviously scared and didn't even know that this could happen, how we frame that discussion has a huge impact on what they ultimately end up deciding to do. And so being as objective as possible, and then even potentially presenting what our typical protocol is for something like that could be very helpful. And so one of the last topics I want to talk about is what you do about the other side. So obviously, if somebody develops a spontaneous pneumothorax and they know that they have bleb disease, now they're thinking, well, what if it happens on the other side? The best we can tell from the literature, the overall risk for contralateral recurrence is about 10 to 20%. This is based on a study here that followed patients for 12 years afterwards and found about a 20% recurrence rate for contralateral pneumothorax. They found that the risk factors for recurrence are if you do a CT scan and notice blebs on the other side, a low BMI, and younger age patients, which I mentioned before. So, I mean, you look at this, you say, well, we could do a CT scan and then we'll know. And then we can tell them that they'll have blebs on the other side. And that's, they might have increased risk of recurrence of a contralateral pneumothorax. This is what blebs look like on the CT scan. They're much more easy to pick up as compared to on a chest X-ray. But the truth is that you're probably just going to cause unnecessary concern and worrying on the patient and the family's part, because this is a pretty good study that, again, followed patients with contralateral bleb disease who had received a VATS on one side, and then they scanned the other side. If you performed a prophylactic surgery on every patient who had bleb disease on the other side, you'd be doing an unnecessary surgery on 75% of those patients. Best we can tell from the literature. So if we could better select out the patients with contralateral blebs that are going to recur, then certainly you could make an argument performing a CT scan. But as of right now, there's really no data to suggest that that's going to be helpful, unless perhaps the family is insistent on it, just from a counseling perspective and wanting to know what their risk is. So in conclusion, I stopped short of sort of creating an actual protocol for what it would look like to manage a patient with spontaneous pneumothorax, because I felt like that would be a little bit presumptive on my part. But if I was going to create such a protocol, here are sort of the big points that I would take out of this. Observation is safe initially, even with patients with larger pneumothoraces. I think aspiration definitely has a role, especially in any patient that you're considering placing a chest tube into, because it has the potential to avoid a prolonged length of stay. The caveat to that is that it does require a lot of interdepartmental coordination and resources, and probably would require a lot of effort to set up. CT scan is not indicated in patients with simple primary spontaneous pneumothorax. And then overall, if you're looking for the thing with the lowest recurrence rate, a VATS with a wedge resection and a pleurodesis still has the lowest overall recurrence rate, if that's what a patient's interested in. So thank you. And I also just wanted to use this opportunity to say thanks to all of the, not only the surgeons and the APPs that have mentored me during my time here at PCH, but also to all of the other departments that I've had the opportunity to work with. I've really enjoyed training here at PCH, and I appreciate all of you. Thank you.
So I think we have a little bit of time for questions. It's interesting because 13 years ago, my son was at Phoenix Children's Hospital with a spontaneous pneumothorax. And so I have to ask you, so knowing what you know now, would you have made the same decision that you undertook when you were in med school?
Yeah, I mean, I've shared this with some people. Obviously I'm in the military, and I was in the military when I developed that. And so I was more sort of like counseled that in order to be deployable, I needed to have a pleurodesis and all that. I got the extreme of the management spectrum. They did a CT scan, they found blebs on the other side, and they did a bilateral chemical, mechanical wedge resection, like pleurodesis. It was a harrowing experience, and I would not choose that, knowing what I know now. But I think my circumstances were a little bit different. But it is helpful to just, I think it's also important just to know that, like, when you're the patient and you didn't even know this was a thing, what you ultimately decide on is so impacted by the way that the surgeon frames the conversation with you. And so just being objective about what the data shows and what the options are, I think, is super important.
So you were deployed on the USS Abraham Lincoln, right? And so is there a second surgeon if you have a problem?
No, there's not, but theoretically there's somebody that can place a chest tube.
All right, other questions? Do you have questions on the chatter?
I'm looking, not yet.
Okay. Other questions?
Dr. Desai?
Yeah, thanks, James. That was great topic. In looking at the chemical fluorodesis and the agents that are used, they're like really old.
Yeah.
I mean, that's what I used in residency.
Yeah.
Older than you are. Thinking now in terms of like a lot of, like mesenchymal stem cell therapy and other types of therapy, is there anything on the horizon that, where you don't do, you said you don't have to do like contralateral lumpectomy,
Right.
that you can either inject into the pleural space or administer, through the bronchial tree into the alveoli that would like either strengthen the plebs or help treat the pneumothorax and reduce recurrence
Yeah, that's a good question.
where natural healing from.
Are they able to hear the question, or should I repeat it?
They should be able to hear within the speaker.
Okay. Yeah.
And advance one slide.
Oh, I'm sorry.
So they can. There you go.
Yeah, to your point, those are like historically used drugs, and best I can tell, they're still in some cases being used. I know recently, there's a paper about using more dilute betadine as an option, but I didn't delve into this topic very deeply, but no, I didn't see anything specifically about using like stem cells or anything like that. But certainly it'd be great if there was a less invasive way of strengthening the lung and preventing this from happening.
Is anybody?
Dr. Egan?
Yeah, great presentation. Thanks, James. Find anything about post-operative recommendations as far as activity goes?
Yeah. Mhm.
Most of the cases, like when we ask them,
Yeah.
during the time that you had the symptom,
Yeah.
or just sitting on the couch.
Yeah. Good. Yeah, the question was about sort of post-operative activity restrictions. There is some literature around whether or not patients are safe to fly and how long after surgery they can fly. There are papers that advocate for, within 2 weeks, patients being able to get back on a plane. And in terms of activity restrictions, there's no evidence-based literature that I could find, and so I didn't throw anything necessarily in the presentation about that. But I would say, by and large, like we typically tell patients to avoid like anything that would require a large like Valsalva. So any straining, for at least 2 weeks after a pleurodesis. Is that evidence-based? I don't think so. But yeah, there's not much sort of great literature about whether or not any of that stuff has an increase or any effect on recurrence rates.
There's one in the chat now that follows that very well. How do you counsel patients about air travel after discharge when they have chosen observation versus chest tube versus surgery? So
Yeah.
Is the type of therapy given for it affect your counsel at all?
Yeah, I think for observation, you want to document like complete lung expansion before you advise them that it would be safe to do something like that. That's what I believe what that New England Journal article that I presented about the observational approach recommended. Again, all of this is theoretical. And it could be that a patient could get on an airplane, a commercial airplane, and be totally fine. Like you don't hear about patients with spontaneous pneumothoraces developing tension physiology on a flight. So again, it's theoretical, but yeah, what I would say is document complete lung expansion prior to allowing them to do anything like that. Dr. Blanc.
Great presentation, thank you. It's not a question, it's just a comment, just as a reminder. In the Southwest, valley fever is still sometimes a presentation that should be kept in mind, that might have some implications for the future in terms of the recurrence rate and what that means. It doesn't necessarily mean that the patient will need to be treated, but it is something that, obviously we've all seen it where the patient is managed with spontaneous recurrence, and that the diagnosis is that, oh, they had a nodule, small capillary lesion that popped basically, and it's obviously needs to be looked at differently from a blood disease, because the recurrence is going to be, if you deal with that spot, then you probably should be okay for the
Yeah.
future. So just as a reminder to keep it on the radar. I'm not, advocating that every patient who comes in with a pneumothorax needs a serology. But just, in case, there's a question about like, well, this is not a straightforward, typical, presentation, to keep it in mind that by the time the patient presents with a pneumothorax, the serology should be reliable. Because typically that means that this disease has been going on for a while, which allows for the seroconversion to be verified test result.
I'm glad you brought that up. I thought about including this patient in the end of my presentation, but I didn't want to confuse things. Dr. Harris and I, like last week, had a patient that presented that with what looked like a classic spontaneous pneumothorax. And I was thinking like, oh, this is perfect. We'll take some pictures. I'll put it in the presentation that I have to give next week. He got worse sort of with observation. So we opted to do a VATS, and we put a camera in. There were 2 liters of blood in his chest. And what he had was, it looked like, an irritated sort of apex of the lung with no obvious pleb disease. And we did a little wedge resection. I think it's growing old now. So
It is growing mold, and he's an immunocompetent
Right.
patient. That's constant. And we typically get, maybe 1 or 2 calls a year from around the valley with a story that the patient was being managed for spontaneous pneumothorax, but then, some pathology or eventually something grows from wherever they got the tissue that shows that element.
I wanted to go back to one of your early slides, which talked about the relationship between the vaping and smoking and spontaneous pneumothorax. Is the thought that they have the blebs and then it's exacerbated by the smoking and the vaping? And if that's the scenario, how does that change your counseling when it comes to presenting options, recurrence with that additional risk factor?
Yeah, I mean, I wish I could give you like the exact mechanism. There's probably some additional like underlying lung injury that occurs that makes them more likely to rupture the blebs. It's definitely a known association. But certainly it's something we emphasize. If anybody presents with a spontaneous pneumothorax, we tell them, look, you're at increased risk for this happening to begin with. And now you add on an additional risk factor with smoking or vaping. And so we do emphasize to avoid those things. I don't necessarily know that we would advocate for like opting for a surgery for that patient necessarily. I think it would just be more counseling, to your point.
Maybe this isn't known, but is how big would a bleb have to be before you could note it on ultrasound? And would there ever be a utility for doing, POCUS or even a patient, if it could be seen, could a patient do their own POCUS? And I mean, like if you wanted to monitor yourself, could you?
Right.
POCUS, could you see?
Yeah. There are some papers about that. The truth is that while there are like dramatic pictures of blebs that you can find on if you Google image them, and those are some of the pictures that I included in this presentation, the majority of them are almost they're occult. So like you see them at the top of the lung on CT scan, they're tiny. I don't know exactly what the detection rate is, or if there are any good papers about using ultrasound for that. But it's hard to imagine, like it's in a difficult spot to see on ultrasound because it's all the way sort of up at the apex, just under the clavicle. And they're in truth in most patients very, very small. But it's a great point.
Since you had everything done, have you had recurrence that you'd like to share?
No, I have not. No recurrence. So yeah, from that standpoint, it did work.